Welcome all. So, we'll start today's session with the prayer.
Shall we all stand for the prayer? പിതാവിനും പുത്രനും പരിശുദ്ധായിക്കും സ്തുതി ആദ്യവന്തേക്കും തന്നെ ആമേൻ. സ്വർഗസ്ഥ പിതാവേ, ഈ മാസത്തിൻ്റെ അവസാന വ്യാഴാഴ്ച ദിവസം ഇതാ ഞങ്ങൾ കടന്നു വന്നിരിക്കുന്നു. തിരിഞ്ഞു നോക്കുമ്പോൾ കഴിഞ്ഞ 10 മാസക്കാലം എല്ലാ വ്യാഴാഴ്ചയും ഞങ്ങൾക്കിതുപോലെ ഇവിടെ വരുവാനും പുതിയ പുതിയ കാര്യങ്ങൾ ഗ്രഹിപ്പാനും കേൾക്കുവാനും അതനുസരിച്ച് ഞങ്ങളുടെ ഈ പ്രൊഫഷനെ അറേഞ്ച് ചെയ്യുവാനും ദൈവം ഞങ്ങൾക്ക് തന്ന വലിയ ഓപ്പർച്യൂണിറ്റിക്കായി നന്ദി. ഇന്ന് ഈ സെഷൻ ലീഡ് ചെയ്യുന്ന ഡോക്ടർ ഫിന്നിയെ അവിടുത്തെ കരങ്ങളിലേക്ക് ഏൽപ്പിക്കുന്നു. പരിശുദ്ധാത്മാവ് അദ്ദേഹത്തെ നയിക്കുകയും ഇന്ന് ഞങ്ങൾ കേൾക്കേണ്ട കാര്യങ്ങൾ അഥവാ പിന്നെ ചെയ്യേണ്ട കാര്യങ്ങളൊക്കെ അത് നന്നായി ചെയ്യുവാൻ അത് ഞങ്ങളുടെ ചുറ്റുമുള്ളവർക്ക് ഇനിയും വരുന്ന തലമുറകൾക്കൊക്കെ ഒരു അനുഗ്രഹമായി തീരുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. വന്നു ചേർന്ന ഓരോരുത്തരെയും അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥനയുടേതായി നന്ദി. യേശു ക്രിസ്തുവിൻ്റെ വലിയ നാമത്തിൽ തന്നെ ആമേൻ. Please be seated.
So, today's talk, just you can see this slide. This is on Mounjaro and Ozempic. So, name doesn't sound that great. It's a odd type of name, but it is very definite that now we are in a new era in term regarding the metabolic syndrome management and obesity management. Almost the days are gone where we used to send patients for bariatric surgery, because bariatric surgery is almost getting obsolete now with all these agents. And when we discuss about these agents with general population, other doctors and other specialty doctors, everyone sees these two agents very skeptically. Everyone thinks that this is something which is odd, it is very harmful. There is a lot of discussions happening among doctors and in social media and all. So it is always worth to know what these agents are and what it is be helpful for us. And obesity does not mean it is a disease for everyone, but obesity can be a disease. It is not a BMI based, it can be a disease based on the complications of the obesity. And if these agents, we will just see the evidence, and if it is very useful, it will give you an insight and confidence and all regarding these agents. And over to you, Dr. Phillips.
Good morning, everyone. I hope you are fresh this morning. We're going to discuss a topic which is the in thing today in the field of metabolic medicine. Everybody is talking of these two words, Ozempic, Mounjaro, and I suppose whether you like it or not, you will come across these words almost every day, either in the social media or in the online meetings. You'll hear about it, and also in the medical colleges and institutions. So I've picked this topic actually for a few weeks. Eli Lilly company, which has promoted this drug called Mounjaro, requested me to just use an awareness session about this particular problem of obesity and how we are tackling it. And the GLP-1 analogs are the big things now in the market. So I'm going to talk about it. 2 days ago, I was in Mysore. I went for an International Society for Bone and Mineral Research meeting. And this is the book all of us got as a free gift. And this is a gift, this is written called, as I don't know how many of you can read, it's called The Weight Loss Revolution, written by one of the top endocrinologists of India called Dr. Ambrish Mittal, who is based in Max Hospital, and he was previously in Medanta. So Dr. Ambrish Mittal has talked about this, and this particular book is actually a very interesting insight from a scientific perspective, but written for lay people to follow. I've already gone through nearly 1/3 of the book. I am reading it. It's very well articulated. And those of you who don't catch everything which I share today, you can order this book on Amazon. Otherwise, you can borrow it from me. You can read it, no problem. It will simplify things for you to read. But it's a very nice book about the weight loss, the myths, the real facts behind weight loss revolution. All right? So I just tell you this is the thing. So today I'm going to talk about the obesity epidemiology and pathophysiology. I have a disclaimer. These slides are provided by the Eli Lilly company. So you will know when a company provides the slides, there will be certain promotional areas. But I thought it will be a good way for us to discuss the facts and fiction about the weight loss drugs. So we need to understand a little bit about obesity, epidemiology, and prevalence, and pathophysiology. Yesterday, I first time prescribed both these drugs for 2 patients, right? For Mounjaro for 2 patients. In my life, I am always slow. I'm not an early adopter. I wait. And my professor, Dr. Seshadri in Velo used to say, don't jump whenever anything new comes. Wait for a while. Suddenly, these obesity drugs have a reputation of coming in with a bang and going out with a bang. Unfortunately, that's been the story of obesity medicine. But these drugs, I think, are here to stay, and that's why I think we should know about these drugs well. So, first part of my talk, the first 10 minutes, I will tell you what is the problem of obesity we are facing. I see medical students in the audience, so I thought I will dwell a little bit about why obesity is such a big problem. Secondly, I will talk about also why these 2 drugs, how do they work, and then how do you actually initiate these drugs. And I want to leave 15 minutes for discussion. I'm sure you'll have a lot of questions. So we will finish in 30 minutes is my goal. So can you believe the statistic that 40% of women in India are overweight or obese? This is published in the Lancet Regional Health publication, okay? 4 in 10 women are overweight or obese. And especially because of, as measured by abdominal circumference. And Kerala is topping the list, all right? So some guilty conscience we must feel, right? We are not doing things right, even though we have all the knowledge. 65% highest prevalence of abdominal obesity in women in Kerala. And we blame obesity on lifestyle, fast food. But there are also genetic factors, but there are many epigenetic factors, particularly the biological factors are important, but the socio-cultural factors. Previously, it was thought to be good to be prosperous, right, in inverted commas. Now it's no longer good to be prosperous. Actually, it will lead to more harm to be prosperous. And behavioral issues are being mentioned in the factors causing obesity. Just one slide, I won't bore you because students are here. You must understand what modulates our eating. We know that we have the appetite regulating center in the hypothalamus, right? That modulates satiety and also modulates appetite and energy expenditure. That is located in the hypothalamus. This is called homeostatic eating. It's controlled by the hypothalamus. There's something called hedonic eating. Now, I've just had breakfast. But if I see a KFC here, I just feel like going and eating. That is called hedonic eating, pleasure-related eating. We see an ice cream, you somehow find that extra appetite to have that ice cream. Pleasurable eating, the liking and the wanting, that is controlled by the mesolimbic system. And then you have some of my colleagues now are on the nutrition hub, including myself. We're trying to lose weight. That is called where we use our prefrontal cortex, executive function, to control our appetite to eat. We don't like the quinoa and the millet with Jyoti sense, but still I will eat it because I know it's good for my health to lose weight. So some of us are doing it, and some of my colleagues have had remarkable results doing that, but they're also combining it with good exercise. And we also must know that there are satiety hormones which are secreted by the intestine, and there are hunger hormones. Hunger hormones is only one, ghrelin, secreted by the stomach. The satiety hormones are what you hear here, the GLP-1, then the cholecystokinin, leptin, which is produced from adipose tissue, and amylin and insulin from the pancreas. These are hormones which regulate appetite and hunger. The culprit in this whole, or the villain in this whole game, is the adipocyte. Normally in all of us, we have healthy adipocytes displayed on the left side. They secrete their adipokines. But in obesity, the numbers and the size of the adipocyte increases. And when that happens, you see the picture below, necrotic adipocyte. That adipocyte starts behaving abnormally when you have too much of it. And what you find is they start secreting inflammatory cells, macrophages, and cytokines, which promote insulin resistance. And fat, if it's too much, it starts getting deposited in sites which are not needed. For example, we know the subcutaneous fat and the visceral fat. Visceral fat is usually in the mesenteric, omental, and retroperitoneal areas. The subcutaneous fat gets deposited in the liver, in the pancreas, in the renal sinuses. Between the muscles, we have fat deposition, intermuscular, and also in the epicardial and pericardial areas. And these are the sites when fat gets deposited, leads to a lot of bad outcomes. The word obesity has become a bad word. It's not politically correct. Now they're changing words. Like alcohol was not a good word, so NASH has become MASLD, metabolically associated steatosis. So obesity also, people feel you're being very derogatory when you say. So the new word is adiposity-based chronic disease. That is a new word, the American Association. It's all rewording the same things, okay? And then the South Asian Federation calls it's a chronic multifaceted, multi-system endocrine disease which tends to relapse. It's a bit like alcoholism. They say relapse is the rule. No? Obesity also sometimes is a big problem. But this can lead to major problems which impair health. And the American Society for Metabolic Bariatric Surgery says that obesity is a condition with low-grade inflammatory state and immune dysfunction. And we see this problem, a big issue right now in our clinics. However, maintaining weight loss with diet and willpower and lifestyle modification is not successful most of the time. You have seen it in my own life. I've lost 5 kgs, I feel great. Next 2 months later, I'm back to my weight. And there is a tendency for us, our homeostatic mechanisms, to pull us back to that original weight. The homeostatic set point in the hypothalamus pulls us back. So when we lose weight, there is a reduced energy expenditure, but the adaptive mechanism is your hunger goes up, you have reduced satiety. The tendency is for you to lose weight. Unless you are very, very determined, most people tend to regain all the lost weight. And don't you agree? Most of you are nodding your heads in agree. So this increased drive to heat and reduced energy expenditure creates a perfect storm for weight regain. And I think how many of you will be feeling your tummies now, I wonder, to see whether you're able to lose and maintain the weight. So the Endocrine Society of India published guidelines for the evaluation of obesity and management. And you can see that the BMI cutoffs for Asian Indians is lower than in the West. In the West, they say obesity is, overweight is 25 to 30. But in India, overweight is 23 to 27 BMI. We have a lower cutoff because at a lower BMI, we are prone to developing microvascular complications of diabetes and other complications. Waist circumference, more than 90 in men and more than 18 in women, and waist-hip ratios. And the very important point is some of us may look lean, but actually if you do a body composition, now Jyoti has got a nice machine. All of you should visit the dietary OP. She's got something called bioimpedance machine by which you can measure your body fat. We may look like we are lean, but your body fat composition may be more fat. So it's sometimes deceptive. Indians have much more body fat compared to the Caucasians. And there is something known as a YY paradox. I don't know if you have heard about it. In the New England Journal of Medicine a few years ago, a picture came of 2 people. One is Dr. Chittaranjan Yajnik from Pune, who is a researcher in the field of metabolic medicine, and one of his close colleagues in America. Both of them have their BMI of 22.3. But the body fat composition is very different from Dr. Yajnik versus his colleague. It shows that compared to the Caucasians, we have more body fat and less lean muscle mass compared to the people in the West. So that is a very, very worrying thing. So body composition also is a factor by which we assess obesity and manage it. It is not enough to just look at BMI and decide to treat a patient. The correct way to treat is, there is an Indian researcher called Dr. Arya, who's located in Canada. Dr. Arya has published much in the field of obesity, and she suggests that the Edmonton obesity staging system is the best way to decide when to intervene and treat obesity with drugs, medications, and also with surgery. And this is the levels by which you say whether obesity, if there's no major complications, you don't have to just give them healthy advice. If it's subclinical, again, healthy eating and physical activity is enough. But once obesity causes complications such as hypertension, dyslipidemia, and other problems, that is when you intervene and go ahead and give them medical therapy and even surgery as an option. So I will just highlight this particular thing. This already I talked about, adiposity-based chronic disease. And when we manage obesity, this is a very good table to remember. See, if you can see, the BMI cutoffs are mentioned on the top. And once the BMI is below 30, you don't really need to give pharmacotherapy. You're good enough to give diet and lifestyle. But then the question is, if they cannot adhere to diet and lifestyle, is when you use these as adjuncts. Beyond 30, you would consider pharmacotherapy. And metabolic surgery traditionally is above 40 kg per meter squared. But if there's more than one obesity-related complication like hypertension, dyslipidemia, you can consider offering them bariatric surgery even at a BMI of more than 35. So lifestyle therapy, we know, includes a diet, which is a hypocaloric diet. Professor Roy Taylor, who works in Newcastle upon Tyne in the UK, is one of the proponents of the anti-bariatric surgery lobby. He says that you can provide good weight loss if you follow a very low-calorie diet. Now, that's something which you must tread cautiously, because if you follow a VLCD diet, you can develop micronutrient deficiencies and other problems. But he has demonstrated and published in the big journals like Lancet that you have equal or reasonably good weight loss, as not as good as bariatric surgery, but nearly there, with very low calorie diets. But you need a lot of determination and ability to maintain it. But he proved it in a NHS-based study in primary care that you could reduce the incidence of diabetes, hypertension, and many of these complications of obesity by diet and lifestyle. There was a diabetes prevention program which was published in the New England Journal of Medicine many years ago, and also in India, which showed that up to 7% weight loss can be achieved by hypocaloric diet, but there is a 58% reduction in the new onset diabetes when you follow this diet. But how many of us can sustain it? That is the big question mark. So this is the study, this is the evidence to show that most people who lose weight, let's say they're about 95 kg, they come to about 85 kg, 5 to 10% weight loss. And then when you follow them up over 62 weeks, you can see many of them, our weight is regaining. And the same story here in this particular publication as well. In the 29 long-term US studies, most of the people who lost weight gradually tend to regain it by 5 years. 79% of the weight loss was regained. So that is where we stand today in terms of just explaining, just follow diet and lifestyle. You know, most of our patients are not able to really get the type of weight loss we are hoping. And the assertion that lifestyle medications, including diet alone, is sufficient is insufficient. We have some evidence to support this. So pharmacological therapy for obesity management till recently, metformin is really not an anti-obesity drug, but it helps in small proportion of people to lose weight. I've had patients who have lost up to 8 kgs with metformin, but not everybody responds well. It has GI side effects. But orlistat was the only drug, the bottom one, what we had till now. It's a pancreatic lipase inhibitor, prevents the absorption of fat, but the maximum weight loss you can achieve with orlistat is 5 to 10%. And then most of the time, once you stop orlistat, the weight is regained. So till 2021, we really had no good anti-obesity drug. Many things came in, rimonabant, which is a cannabinoid receptor, that came in and went off. Then we had other drugs which came in. The names are many, but they all were left after 1 year, even after getting approval from the FDA. Within a year, they were all withdrawn. But semaglutide is the drug which is now doing the waves. Last year, I was visiting the US. I visited my cousin in Florida. He's on Ozempic. I visited another cousin in Texas. He's on Ozempic. Now, Ozempic is like everybody, and I was quite surprised. The good thing is it tends to make them lose weight. But they also, not only the body fat goes, the lean mass also goes. Remember, for every 10 kg you lose in fat, there is a 3 kg loss in lean muscle. And that is something you must remember. And unless you give good protein diet, which generally our diets are deficient, unless you do resistance muscle exercises, it's very likely that you will lose your lean muscle, and it's not easy to regain lean muscle. So we need to have a word of caution when we use these drugs. Semaglutide is being used in diabetes, and the good thing about semaglutide, it's one of the GLP-1 analogs, is that it causes also improvement in cardiovascular risks, renal risks, and it has a lot of other benefits beyond just sugar lowering and weight lowering. There are benefits beyond just these things. So usually these are all once weekly injections which are given, and injection sites like insulin, you can inject them. Starting dose is 0.25 once weekly for 4 weeks, and you gradually build up the dose. Tirzepatide is what Lilly is marketing as Mounjaro. That is a real drug. This is a GLP-1 plus a GIP analog, and I'll talk about it shortly. So these are also started at 2.5 mg weekly. Over 5 months, you build up the dose. If the patient can tolerate the dose, you build up to 15 milligrams. And metabolic and bariatric surgery, most societies and the surgeons, they say the cutoff is now 35, whether or not you have obesity-related complications. But traditionally, we were following 40 as a cutoff to offer bariatric surgery. And many devices are there for temporary loss, such as adjustable gastric band. So if you look at the various bariatric choices we have today, sleeve gastrectomy is what Sujit Philip and the team here in Believers uses the most, because they feel their side effects are least, and they find that 80% of the patients in India are also getting sleeve. But the problem is it's not as effective as a Roux-en-Y gastric bypass, which is probably the best. It's a maladaptive, maldigestive surgery. But the problem is there's more incidence of side effects like dumping syndrome. But you have reduction of weight and type 2 diabetes significantly lowered. And adjustable gastric band is a temporary measure by which it's temporarily they close the stomach lumen area, and then you lose weight. Some people put gastric balloons in the stomach and inflate it so that there is no space for food to enter. You get early satiety and people lose weight. So, but these are all, the tendency is the weight tends to regain after some time. For a temporary weight loss, it may be a good option. So in summary, remember, obesity is no longer something, it's not a cosmetic problem. We are dealing with a disease. That is a big shift which has occurred in our thinking. There's nothing called healthy obesity. All right? It is unhealthy. I'm spelling it out in words because there are complications, the knee pains, the uric acid going up, the cardiac, renal, all these complications are due to obesity, and this prevalence sadly is going up in India, the US, and most parts of the world, and Kerala is not way behind, it's right at the top. And it's a complex interplay. It's not easy to treat obesity. Management has to use both diet and lifestyle, pharmacotherapy, and surgical interventions. Sustaining weight loss is the main carry home from this particular set of slides. It's difficult to maintain because the body's tendency is to push you back towards gaining weight. Okay, so I will talk about this tirzepatide, this molecule a little bit. Surmount is a study which was done on this particular molecule. It's Surmount 1, 2, 3, 4, 5. I will focus on just 2 or 3 of those studies. So as I mentioned a little while ago, glucagon-related peptide. I'll tell you a small story. Have any of you heard how this GLP-1 molecule was discovered? Anybody remembers? Except my endocrine team must have heard it many times. One day, this is where the power of observation comes in. There was, in Australia, there was a man who was bitten by a lizard, all right? And he fell unconscious. People thought he felt unconscious because of the fear of lizards. Yesterday, I heard about somebody who fell unconscious seeing a snake in the zoo. That's a different matter. But some of us are afraid of reptiles. But this man was bitten by a lizard. But there was an Australian medical student nearby who was interested. Why did he fall? Is it just fear? No. He happened to go and do a GRBS, glucometer, and he found the sugar was very low. And this monster or this lizard was called the Gila monster. He went and analyzed the saliva, and he found that the saliva of this lizard contains a substance called exendin 4, which is very similar to the human GLP-1 secreted from the intestines. And that's how GLP-1 was discovered. And later on, Dr. John Young in US analyzed this properly, and he discovered this molecule called glucagon-like peptide. It's a natural substance produced in our body. In response to glucose, it stimulates the release of insulin. That is what GLP-1 is. And GIP is glucose-dependent insulinotropic polypeptide, which is also an agent which acts similarly. But if you compare GLP-1 and GIP, both of these, when you give GLP-1 analogs, basically these agents are all GLP-1 receptor agonists. They go and bind onto the GLP-1 receptor. They reduce the food intake. Both GIP also reduces food intake. And they reduce glucagon. They cause early satiety by reducing the gastric emptying. And when you combine these two, the effect is more pronounced. So semaglutide is just a GLP-1 receptor agonist. And GLP plus GIP is what is tirzepatide. And that's what we're going to discuss today. So tirzepatide is, as I mentioned, a molecule which is based on the native GIP sequence. Imagine this is a nice cartoon explaining that the GIP receptors, the GLP-1 receptors, when these molecules bind onto this, these cause insulin release and they cause the effects. And the good thing is the half-life is long, so you don't have to take daily injections of tirzepatide. You can do it once a week. And there's no dose adjustment needed even if you have mild to moderate renal dysfunction or liver dysfunction. Mounjaro, or tirzepatide as we know it, causes GIP and GLP-1 receptor agonism. It cuts down your appetite and caloric intake. The main way it works, it reduces that hedonic thing. You remember that cartoon I showed you, the hedonic eating. Actually, some of my patients have come and told me, I used to enjoy going to Pizza Hut, but now I go to Pizza Hut, I feel like a terrible change. A bit like an early pregnancy, My wife became a vegetarian in early pregnancy. She wouldn't like anybody making fish anywhere in the near vicinity. She would tell them, stop. Tell them to go and turn off that fish smell. For people who love fish, so that's how a bit like this. That's what happens with tirzepatide and semaglutide. Sometimes you get turned off by the food. And so one of my patients stopped his semaglutide because he says, I want to enjoy that pizza once in a while, okay? What I'm trying to say is that hedonic part of the eating, that craving you have to eat certain foods is gone. You may not want to eat ice cream. That may happen when you take this drug, okay? Reduce the intensity and preference for high sugar and high fat foods. GIP receptor agonism in adipocytes regulates the glucose uptake, and by this combined action, Mounjaro lowers the body weight, resulting in greater fat mass and lean mass. Remember, this is an industry-provided slide. That's why this word is. But actually, the truth is, it causes significant weight loss, but there is some amount of lean muscle mass. That is the facts which I must do. And in the Q&A, I'm sure you will have some questions about it. We'll take it. So there were 5 trials done on tirzepatide. Surmount 1, 2, 3, 4, 5. In Surmount 1, they used Mounjaro in 3 doses, 5 milligram, 10 milligram, 15 milligram. More than 2,500 participants, fairly a good duration of the study, 72 weeks up to 84 weeks. First, they compared it against a placebo. Surmount 2 was Mounjaro against placebo. Weight management in diabetic patients. Surmount 3 was weight management after a period of intensive lifestyle modification. 4 and 5, how when you stop the Mounjaro, what happens? Do they regain the weight? That's what they checked. And in 5, this is an interesting study, which I will talk about. They compared head-to-head tirzepatide versus semaglutide and see how they fare. So we will just go through the highlights of this study because time is also a constraint. Surmount 1 is the one with tirzepatide versus a placebo. This is proof of concept they're showing, whether it works. And that's what it shows. And remember, we don't start tirzepatide at the full dose of 15 mg initially. We always start for 1 month on 2.5. We build up to 5 milligram, then go up to 7.5. Over 5 months, we build up the dose because some patients have very bad nausea, vomiting. We may have to stop it or go at a lower dose. So this is a study which went on -2 weeks, means first 2 weeks they put them on the trial to see if they are able to tolerate the drugs and see whether everything is okay before you initiate the trial. The treatment is going on for 72 weeks. And we are looking at the outcome. This is a phase 3 multi-center double-blind trial. And the endpoints which you're looking at was percentage change in weight from the baseline, percentage of population with weight reduction of more than 5%. What proportion of the population had a weight reduction of 5%? And weight reduction was seen as early as 4 weeks. The average weight loss was 16% weight loss when you use tirzepatide 5 mg at 72 weeks. But when you built up the dose to tirzepatide 15 mg, you had 22.5%. Remember, diet and lifestyle, maximum 5 to 10%. But this, you're getting nearly double the amount of weight loss. What do we get in bariatric surgery, if you remember? 25 to 30%. So we are nearly there. But it's not as effective as bariatric surgery, but definitely most patients don't want surgery, right? So this is a very good option. What percentage of people achieve weight reduction at 72 weeks? 9 out of 10 patients achieved 5% weight loss, and 75% achieved more than 10% weight loss with tirzepatide, even the lower doses, 5 mg. That's what I'm trying to highlight, not at the full dose. And more than 50% of the participants crossed the 20% weight loss barrier with tirzepatide. So basically I'm trying to say it's very effective in weight loss of up to 15 to 20%. Persons with tirzepatide also improved on their body composition analysis. Now, the DEXA scan is the best scan. Our current DEXA machine, we can only measure bone density. We don't have the applications to measure the body composition, but hopefully our machine has become 10 years old. I'm hoping that the management will gently support us as we upgrade to the next DEXA machine, which can measure more of these things, because obesity is a big issue. But what I want to say is there is reduction in fat mass demonstrated on the DEXA machine. The fat mass reduced from more than 25%, it came down significantly, but the lean mass also did reduce. Also, Mounjaro or tirzepatide reduced the systolic blood pressure, the diastolic blood pressure, the lipids, and the triglycerides. All these reduced beyond just sugar and weight reduction. So this is the head-to-head trial which everybody was interested in. Which is better? Now most of my patients want to know, should I take tirzepatide or should I take semaglutide? Semaglutide has been in the market for the last 3 to 4 years, right? Tirzepatide just came in a couple of months ago. So we don't have that much of data as much in India as much as we have with semaglutide. Obviously, semaglutide is a wonder drug. Numerous studies have shown it reduces the cardiovascular mortality and other complications. So if you look at the MTD stands for maximum tolerated dose. Not our Indian people. When I worked in the UK in 2014, I used liraglutide a lot. And I find that compared to the Caucasian patients who were my patients versus the Indian origin patients, somehow we had much more nausea, vomiting with liraglutide. Victoza, as we used to call it. Whereas our Caucasian patients seem to tolerate it better. So we must realize that everything which we see in the international data may not be applicable, but some of these studies have included Indian patients as well. And so Mounjaro 15 mg maximum tolerated doses versus semaglutide 2.4 mg dose. This is also a phase 3 double-blind study. At 72 weeks, patients taking Mounjaro experience a mean percentage body weight reduction of 21%, versus those with semaglutide, it reduced it to only about 15%. And 35% of patients taking Mounjaro demonstrated a mean weight reduction of more than 25% at 72 weeks. The waist circumference reduced by about 20 centimeters. And what happens if you discontinue Mounjaro? So the fourth study of SURMOUNT was on weight reduction. It showed that 26% of patients, their weight reduction was achieved, but 9.5% of patients regained the weight. Can you see that? The regain is occurring in those who stop Mounjaro. So remember, actually, obesity is a life chronic disease. The truth which we often fail to tell our patients is once you start these drugs, actually you should be taking it lifelong. Now brings in perspective. It's not a drug which you start and you stop after 2 months. We see many practitioners prescribing it for 1 month, 2 months, and the patient stops it. They can't afford it. So actually you need to have a honest conversation. When you're starting a drug, I'm starting it for a long term. Like diabetes and hypertension long term. You have to take it regularly. But the minute you stop it, you're going to regain weight. So don't think it is like a wonderful drug which will not have to be continued. So the cost considerations come in. What about the side effects is what I think many of you are worried about, and Arun talked about it in the introduction. Many people are scared about the side effects. Actually, if you see that, nausea, diarrhea, and vomiting are the highest side effects. In fact, most of the minor side effects like nausea, vomiting are common, but they are manageable. Whereas the major side effects are very rare. That's something which I want to mention. Nearly 30% of patients on tirzepatide will develop some nausea, vomiting, or constipation and diarrhea. But these will usually settle down in about a few weeks. That's what you need to reassure them. Better tell your patients beforehand this may occur. I often tell my patients this drug may cause this side effect, especially dapagliflozin. I tell them you can get UTIs. And once you tell them, the patient is able to accept it. Then when they do get the UTI, and they're able to stop it immediately. But so most of the side effects are there in all the doses. At higher doses, you have higher side effects, and adverse reactions in the trial I've shown here. So basically, none of these adverse events led to any death, but some of them had serious side effects, up to 3.5% in the semaglutide group versus 4.8% in the tirzepatide. Slightly higher serious side effects, but they were not statistically very significant. So the question is, the tirzepatide reduces body weight by an average of 16% with 5 mg and 22% with 15 mg. And there is a superiority in weight reduction in tirzepatide as compared to semaglutide. There is improvement in the key cardiometabolic parameters, and the most common adverse reactions were GI in nature and mostly mild to moderate. So I want to close with the dosing and the side effects which you are worried about, particularly pancreatitis, retinopathy. I'm sure these are the things which are on your mind. I'll talk about that. So usually we start at 2.5 mg a week, go up to 5 mg, then increase to 7.5 mg. So 4 injections, and then 10 mg, then 12.5 and 15 mg. You stop it if the patient is not able to tolerate it. There are a lot of resources on the net, and the pharma company will give you a lot of these resources you can start your patient on. The important thing is when you start them with the existing diabetic drugs, usually you don't need to change the dose of metformin or SGLT2 inhibitors, but sulfonylureas and insulins, the dose will have to be reduced because they may go into hypoglycemia. No dose adjustment needed based on age, gender, and ethnicity. And in mild to moderate renal and liver failure, there's no problem in giving it, but in severe ESRD and severe liver failure, there is not enough studies. They have not included such patients in their trials. Because I told you GI side effects are the most common, you must tell your patients not to eat large portions. Eating small portions more frequently is important. Good to avoid being mindful. There's something called mindful eating. Yesterday I saw a picture on social media of a plate. The plate has got food, but on the left side column there is a phone. So we are all watching the phone while eating, right? So that is called mindless eating. This is also a problem. So I think mindful eating, sometimes we talk to people and we don't realize what we're eating, or watching telly and eating, mindless eating. So it's very important to be mindful, to stop eating when you're a little bit full. I think Shamnad in his videos beautifully, I love seeing Shamnad's videos on the social media. He will talk very nice, simple, small messages about diabetes, how you can treat it. Avoiding eating when not hungry. This morning I didn't feel hungry, but I still wanted to eat breakfast just because by the clock I'm eating. But maybe you can avoid some of those eating. Maybe we can reduce to 2 times a day. Staying hydrated is important. Avoiding high spicy food and fizz and alcohol. The last slides. What about pancreatitis? That's a scary side effect, right? the prevalence in the studies are 0.2 to 0.4%. So 2 in 1,000 patients will get it. So is that the risk higher than the risk of getting hit by a car when you cross the road? Probably equal, right? Second, what about the risk of dying from a complication of cardiovascular disease and obesity related thing? Probably lesser. But that is a fact. You must tell your patients there is a little increased risk of pancreatitis in about 1,000 people, maybe 2 to 3 people may get it. If in that case, you must warn them what are the symptoms of pancreatitis and tell them to stop it. Denmark and the Scandinavian countries have an excellent registry of all their population. They monitor all the side effects. Recently, in the New England Journal of Medicine, they published the incidence of retinopathy, non-arteritic anterior ischemic optic neuropathy, is slightly higher in the group who took this. Now, we don't know if that's whether it is significant or not. Most of the authors and the senior professors say that this is not really a concern, but it's good to do a retinopathy check before you start them on this medicine. And finally, in pregnancy, you don't want to give it, and breastfeeding also, we don't know. So I want to close with that. If any of you want to take a photograph of this, you have a post-test quiz on what I just told, whether you'll remember the points which I told, okay? So you can just use your phones, take a photograph while we have the Q&A session, and you can have, I'm open to questions. We have still about 10 minutes to discuss. This clock is a little bit fast, I think. All right, okay. So thank you very much, and I'm happy to take questions from you.
Thank you, Philip, sir. So, anyone want to contribute? I think I will hand over to Mohan sir because he's using oral semaglutide ribosils for a long time.
Actually, treating a diabetic and obesity is go hand in hand. So I am using this molecule since a long time, and my experience I will share you. Because we don't have a reversibility of the many diseases like kidney disease. The nephrologist is here, and how to arrest the progression of the nephropathy. So we have studied and published a few cases in journals regarding the arresting and reversibility. Even one rich businessman from the Tiruvalla consulted me regarding with an creatinine of 1.9. So I advised that you can have various drugs which can arrest the progression and reverse it. So I started on this semaglutide, and his serum creatinine returned to 0.8, and all his brothers and sisters are working in US, and they are all using this molecule. So he is very confident about that particular molecule. Then I went through the liver disease. That's also the trials are going on. So reversibility of the liver disease, many untreatable disease which can cure or partially reversible. Then sleep apnea, OSA, that's one of the great problems that can reverse. Even infertility, that studies are going on. Even dementia, that studies are going on. So how far it is useful in clinical practice, we have to wait and see. And I think personally most of the patients, except nausea, vomiting, so I stopped few patients. Otherwise, it's a molecule which can modify the certain disease considerably than any other drugs, I can assure it. And no one developed any pancreatitis in my patients. But I should be cautious, and optic retinopathy. Then family history of thyroid carcinoma, that is another problem that also to be asked regarding any family history of thyroid carcinoma. That should then only initiate. There is a drug which is actually probably helpful in these lifestyle diseases and reversibility.
Thank you. Actually, medullary thyroid cancer, it can cause C-cell hyperplasia and calcitonin levels can rise. So it's good to ask about history of MTC in the family before you do. I forgot to mention about the cost of this medicine, right? All of you want to know because the pocket has to bear the cost, right? When you start on Mounjaro or semaglutide, the oral semaglutide Rybelsus, which Sam talked about, is costs about 10,000 rupees a month approximately orally, but you have to take it daily. Whereas injectable semaglutide, Ozempic, which is just come into the market, that one costs about 10 to 14,000 rupees a month. That is for 4 injections. So each injection you're poking subcutaneously is about 3,000 rupees, 3,500. Mounjaro is more expensive. In the lower doses of 2.5 mg, it's about 14,000. But when you reach the higher doses of 10 to 15 mg, it's 27,000 rupees a month. So think about not just starting, but can the patient sustain it? That's affordability. You need to think and talk to them truthfully about what is the cost involved in maintaining the cost.
This context, I'm using semaglutide Wegovy. We don't have Ozempic as of now here. The Novo Nordisk has got 2 brands for semaglutide. One is Wegovy. Wegovy is for weight reduction, and Ozempic is for diabetes. Both are actually same because of the insurance issues in Western countries, because all the people go and buy these agents and deplete the insurance. So that may be the reason why they kept two brand names. So Wegovy is here, and I'm using Wegovy for the past 2 months, 2 months, and every day 1 or 2 prescriptions do happen. And there is a way to cut down the cost. I don't know whether it's appropriate or not. They have the pen 0.2, 0.25, 0.5, 1, 1.7, and 2.4 mg pens are available. 0.25, 0.5, and 1 mg and 1.7 mg pen all have the same price. So 0.25 pen means it has got 1 mg, we can use for 4 doses. So for 4 doses, that is for 1 month, we have to spend nearly 14,000 rupees. But the same cost is for the 1 mg pen also. 1 mg pen is for the 3rd month. But what we can do is we can buy the 1 mg pen, and if you just rotate the pen, it will be 1 mg. But if you rotate it 1/4, it is click, click, click. So 72 times 72 clicks, it will becomes 1. So if you rotate it 1/4, and if you click, if you inject it, we can reduce the cost of a semaglutide by 1/4. And we can maintain the patient with a monthly cost of around 5,000 rupees. Not we have to go for 14,000, 15,000 rupees. And that is one thing, but the company people don't like it. But this is how I used to go with the Wegovy. And next thing is we are all concerned about the rebound weight gain after stopping these agents. So as per the company policy, they all want these agents to be continued lifelong, and they want the company's profit and this to grow big and big. But one thing we can all do is we always start in a graded fashion. We start in a low dose and titrate it to high dose. Maybe Mounjaro will go up to 10 mg. 15 mg is too high for our population. But stopping at that point, all of a sudden, there is a rebound weight gain, because all of a sudden, lot of cravings and all do happen. And our population, it may not be possible to continue indefinitely. What I always do, when I get the desired weight reduction, I then reduce the dose gradually rather than stopping it abruptly. From 10 mg, I will go to 7.5, then 5, then 2.5, and maintain the 2.5 for some more months. And by that time, we have to emphasize on diet and lifestyle management. And that time, the diet and lifestyle management should maintain the remission. So that is the one way we can stop these agents. And the Mounjaro, I reduced this dose and stopped like this. But Wegovy, it is recently started, and I'm planning. But maintaining the Wegovy is also very easy, because we can buy a 1.7 mg pen, and we can use this 1/10 dose by just click base, and the monthly cost will be around 2,000 rupees. So in that case, we can give a maintenance dose of Wegovy also if you're planning to stop.
Age limit, we don't use it in above 75 years. Usually we don't use it. Younger children also we don't use. I am not sure. Is the age group 18 or 12? Huh? We have not. I don't think it's pediatric, as I said. Dr. Jijo, any thoughts? No. I think we have to be cautious. We are seeing a lot of childhood obesity. That's the truth. But I think in childhood obesity, I don't think this is FDA approved for a pediatric population. Dr. Anulekha, I'm not sure. Has it been approved? No, I'm just I don't remember reading that line. Yeah.
One important thing, we have to stop the gliptins while you're using this agent.
So remember, this is a GLP-1 analog, and we know that the DPP-4 enzymes are what break down it. So it doesn't make sense to use a DPP-4 inhibitor and a GLP-1 together. So you'll have to stop the gliptins on board. Yes. Any expert comments?
I think Dr. Sunal Nisar is using Wegovy. I think he can share some.
When I was visiting the States, I stayed with an emergency physician who works in the Methodist Hospital in Dallas. He was telling me that they feel, ED perspective, they are seeing a little bit more higher risk of pancreatitis ever since this Ozempic boom has occurred. So just a word of caution, but we don't have evidence. I want to also hear from all of you. I asked in my ISBMR conference to the senior endocrinologists, have any of you had a pancreatitis in your practice? They're all quick to jump onto the bandwagon. They said none of them have seen any. But just be aware, there could be a risk of pancreatitis. Sir, the mic. Sir.
Artist from Mavelikara, obese around more than 40 BMI.
Yeah.
His problem is reactive hypoglycemia. So he is a pre-diabetic. So that I started him on this particular molecule, and the reactive hypoglycemia also subsided. That's one of the things, along with the glucosidase inhibitors. So obesity with reactive hypoglycemia with you can combine together alpha glucoside inhibitors plus this molecule. So very good molecule is happy with the medications, injectables.
This is SGLT2 is for atherosclerosis. Atherosclerosis prevention is very good. So when we use the SGLT2 inhibitors, the problem is the peripheral artery disease as well as the non-fatal stroke is increasing. The studies are shown. So when you use these GLP-1 inhibitors, they will reduce the atherosclerotic, that is MI, CVAs, and even the peripheral artery disease are improved with the use of GLP-1 receptor. So it is very good in that sense.
Anyone want to contribute?
Any other questions?
So I think we can wind. Thank you very much. And yes, sir.
It's not related to your topic, but can I request all of you who are seniors here, can you just request your young doctors, you take medicine alone, you have about 100 people working with you. Don't you think they should come here and listen to this? Can you please encourage them to do their pre-round? They're all doing pre-rounds at the moment, so that as soon as you get there, they're ready. Surgery. Can you please get your people to come and listen to talks like this? I mean, unless we develop our next level, so unless you tell them, they won't, because they're only interested in impressing you now when you go there for rounds. So please encourage them to do their pre-rounds at 7 o'clock on Thursdays, and tell your juniors, I'm glad to see seniors here, but where are your middle level? Where are your juniors? Please take it as a earnest request from me to make sure that on Thursdays they do their pre-rounds at 7 o'clock and come for this from 8 to 9. I promise we'll stop at 9 and then take them for your rounds. Okay? Thank you so much.
Thank you, sir.
Thank you all.